Hello everyone, today we will explore mechanical spinal abnormalities, focusing on low back pain, scoliosis, postural dysfunction. These conditions are among the most common presentations in musculoskeletal physiotherapy and are primarily driven by biomechanical, neuromuscular, and movement related factors rather than systemic pathology. Understanding these conditions requires a strong foundation in spinal biomechanics, motor control, load management, and clinical reasoning. What are mechanical spinal abnormalities? Mechanical spinal abnormalities refers to conditions where symptoms are provoked or relieved by movement or posture. There is no serious underlying pathology. Dysfunctions arises from impaired load distribution, movement control, or tissue capacity. These are often classified as non-specific spinal disorders, especially in low back pain. Spinal biomechanics overview. The spine functions as a load bearing and movement structure. Key components include vertebrae, intervertebral discs, facet joints, ligaments, muscles. Functional roles. First one is stability, provided by passive and active structures. Second, mobility, allowing flexion, extension, rotation. Third, load transfer, distributing forces through the spine. So the core concept, optimal function depends on the balance between mobility, stability, and motor control. Disruption of the balance leads to mechanical dysfunction. Low back pain. Overview. Low back pain is one of the leading causes of disability worldwide. Most cases are classified as non-specific low back pain, meaning no single structure is clearly responsible. Mechanism of low back pain. Tissue overload, repetitive strain, poor load tolerance. Second, movement dysfunction, poor motor control, altered movement patterns. Third one is psychosocial factors, fear avoidance, stress, reduced activity levels. So let's talk about clinical presentation. Clinical presentation, localized or radiating pain, stiffness, reduced mobility, pain with movement. Symptoms often vary with posture, activity, load. Subgroups of low back pain. Advanced clinical reasoning may classify LBP into movement control impairment, mobility deficits, pain dominant presentation. So the next one is scoliosis. So what is the definition of scoliosis? Scoliosis is a three-dimensional spinal deformity involving lateral curvature, vertebral rotation, structural asymmetry. The types of scoliosis are structural scoliosis, fixed deformity, often idiopathic. Functional scoliosis, reversible, caused by posture or muscle imbalance. Biomechanical impact. Scoliosis leads to asymmetrical loading, muscle imbalance, altered spinal mechanics. This can result in pain, reduced function, and cosmetic concerns. So let's talk about the clinical features. So uneven shoulders, rib, hump, pelvic asymmetry. Postural dysfunction. Definition. Postural dysfunction refers to sustained abnormal alignment of the body, leading to mechanical stress. So what are the common patterns? So forward head posture, rounded shoulders, increased lumbar lordosis, and kyphotic posture. Mechanisms. Postural dysfunctions leads to muscle imbalance, altered joint loading, reduced movement variability. So what is the clinical presentation? Dull aching pain, fatigue, symptoms worsening with prolonged positions. So the other one is clinical assessment. So what are the subjective examination? The key focus should be aggravating and easing factors, posture related symptoms, functional limitation. Observation, assess spinal alignment, posture, symmetry. Movement assessment, evaluate flexion, extension, rotation. Look for pain reproduction, movement quality. Palpation, identify muscle tightness, tenderness, joint stiffness. Functional testing, example sit to stand, gait analysis, and lifting mechanics. Clinical reasoning framework. A modern MSK approach includes step 1, identify dominant impairment, mobility issue, stability issue, motor control issue. So the other one is step 2 is assess contributing factors, muscle weakness, joint stiffness, movement habits, psychosocial influences. Step 3, classify presentation, acute vs chronic, mechanical vs non-mechanical. So physiotherapy management. First one is education. Patients should understand the pain mechanisms, importance of movement and load management. Exercise therapy for low back pain, core stabilization, graded strengthening, movement retraining. For scoliosis, corrective exercises, posture specific training, breathing exercises. For postural dysfunction, strengthening weak muscles, stretching tight structures, ergonomic correction. Motor control training, focus on movement quality, coordination, functional control. Manual therapy may include joint mobilization, soft tissue techniques used to support pain reduction, improved mobility. So, load management, patients should gradually increase activity and avoid sudden overload. Evidence based perspective. So, modern physiotherapy emphasizes active rehabilitation over passive treatment, individualized exercise programs, by biopsychosocial approach. This aligns with the concepts from Greaves and contemporary MSK practice models. So, clinical case example, consider a patient with chronic low back pain, poor sitting posture, reduced core strength. Clinical reasoning, movement control impairment, postural dysfunction, management, education, core strengthening, posture retraining, gradual return to activity. So, what are the key take home points? So, mechanical spinal conditions are movement related disorders. Balance between mobility and stability is essential. Exercise therapy is a cornerstone of management. Clinical reasoning guides individualized treatment. So, mechanical spinal abnormalities highlight the importance of understanding movement, load, and function. As physiotherapists, our role is not just to treat pain, but to restore optimal movement and improve long term function. So, thank you for joining this advanced discussion, and I will continue sharing more high level musculoskeletal physiotherapy topics. See you in next video.